Today, the topic is mental health and substance abuse. And I think what we need to understand is that we're going to be covering mental disorders associated with substance abuse. And I trust that this workshop would be an informative workshop so we can act on an informed basis at the different levels that we are working in the respective fields in substance abuse treatment, relating to early intervention, pre-treatment, treatment and referrals to the professionals and aftercare. So yes, thank you. So yes, we're going to be focusing on dual diagnosis. And just what is the meaning of dual diagnosis? It's a person with dual diagnosis has a mental disorder and an alcohol or drug problem. These conditions occur together frequently. About half of the people who have a mental disorder will also have a substance use disorder at some point in their lives, and vice versa. The interactions of the two conditions can worsen both. So we're looking at an integrated treatment process. And I welcome you. I have many speakers on the program. So we will have engagement later on. As I said, continue with your questions in the chat, and these questions will be answered at a later point in time. Our first speaker to give us an overview and to assist us in understanding some of the concepts that are going to be utilized today would be Katlego Rafapa. He's busy completing his master's degree in clinical psychology. And over to Katlego.
Morning again, ladies and gentlemen. As Gibson explained, I'm going to be covering around 4 broad areas. So I'm just going to cover them generally, but I will be detailed as possible. I'm going to start by defining what the DSM is. I'm sure you guys know that some people are diagnosed with mental disorders. If you've ever wondered where these mental disorders come from, they actually come from the DSM. Okay, so just a general outline of my presentation today. So I'm going to start with just defining the DSM, and I'll also touch on psychosis. I know Dr. Markham mentioned psychosis in his presentation, so I'll just clarify exactly what that is. Okay. Okay, so I'm going to start with the DSM. Sorry for that, guys. We're just experiencing some technical difficulties. So I'm going to start with the DSM-5. So generally, as I explained, there's a lot of mental disorders that are diagnosed. And if you've ever wondered which book or manual they use to diagnose, the Bible of diagnosis is the DSM-5. The first DSM came out or was published around 1952. In its current form, it's the DSM-5 text revision. It's very important to note that the reason it has the text revision is that the first actual DSM-5 was published in 2013 around May, and then research continued, and then they revised some of the mental disorders that were contained in the original DSM-5. And then from the research and the revision, they then developed the DSM-5 text revision. The text revision came out around last year. Now, it's very important to also note that the DSM mainly comes from 2 sources, or the mental disorders that are contained in it. It's from clinical practice, more specifically from psychiatry. So as psychiatrists see patients, they develop new diagnostic criteria, and then they research those diagnostic criteria, and it takes years and years and years to actually come up with those mental disorders. Secondly, it also comes from research that is done academically in universities. There is a consensus on some of the mental disorders, and then they include them in the DSM, and then it's published. So this is what they use to actually make mental diagnosis for mental disorders. Secondly, how does the DSM work? So currently, the DSM has around 20 chapters of mental disorders, plus one chapter on what's called neurodevelopmental disorders. A nice way of looking at the DSM-5, it uses what's called the lifespan approach. What we mean by that is that the first chapter, the neurodevelopmental disorders, deals specifically with disorders that occur during early development or childhood. Some of these disorders include, for example, your intellectual disability, your communication disorders, what's called childhood onset fluency disorders, commonly known as stuttering. The more famous or common ones that we might know include autism spectrum disorder and attention deficit hyperactivity disorder, or commonly referred to as ADHD. So that's the first chapter of the DSM. It has all your neurodevelopmental disorders that occur within childhood. The rest of the chapters, the other 20 chapters, is mental disorders that are diagnosed in adults. These include, just to mention a few, your bipolar disorders, your depressive disorders, for example, your major depressive disorder, commonly referred to as depression. And also your anxiety disorders. It also has what Dr. Markham mentioned, personality disorders. So for example, borderline, which we will discuss briefly later on. It also has personality disorders like antisocial personality disorders, which we'll also touch on a bit later. Okay, in addition to the 20 chapters on mental disorders for adults, plus the one chapter on children, the neurodevelopmental chapter, it also has a chapter called Other Conditions That Might Be a Focus of Clinical Attention. This chapter contains those psychosocial and environmental problems that either might be the reason someone is consulting a social worker or a psychologist or a psychiatrist. So these include such psychosocial or environmental problems such as relationship problems, it might be educational problems, abuse or neglect. So it's those issues that normally social workers deal with effectively. There's also, actually the last chapter includes those. So it's also important to note, in some instances, you might diagnose a mental disorder, right? And you might also diagnose another issue of clinical focus. So I'll give an example. So let's say someone presents initially in a counseling or therapeutic setting, right? They present with major depressive disorder symptoms. And then the therapist or the psychiatrist diagnoses them with major depressive disorder. Then during the history taking, it comes out that the person is actually experiencing physical abuse at home. Then you'll go to the chapter entitled other disorders that might be of clinical importance, which is your psychosocial and environmental problems. So you might, for example, diagnose major depressive disorder, and you might also diagnose physical abuse if they're experiencing physical abuse. The reason we do that, obviously, is that whatever presentation is presenting in the therapy room is impacted by that abuse. So that's why you'll diagnose both. Okay. And also, it is also very important to note that this manual is designed specifically to be used by trained clinicians. This includes, for example, medical doctors, psychologists, and psychiatrists. The reason they do this, or they limit this, and this is actually a recommendation from the American Psychiatric Association, which are the people that gather research for the DSM and who actually publish it. The reason they're doing this is to minimize misdiagnosis. So the assumption is that if you're trained in the manual, there'll be less misdiagnosis. I'm not saying it will completely remove misdiagnosis, there'll just be less misdiagnosis because it's only used by people who were actually trained in the manual. Now, just to give a brief outline of what the manual has. So as I mentioned, it has one chapter of neurodevelopmental disorder and around 20 other chapters on disorders that are diagnosed in adulthood, right? Each chapter contains mental disorders that have common symptoms. So I'll give an example. The chapter on depressive symptoms, it has your cyclic disorders, it has your major depressive disorder, it has persistent depressive disorder. So all of those are contained within that one chapter. Now, the commonality amongst those disorders is that the individual will experience feelings of unhappiness. They'll also feel hopeless, and they also have an irritable mood. So that's how they package those chapters, and that's how they actually order the mental disorders. Now, what exactly is contained in each mental disorder? There is what we call a diagnostic criteria. A diagnostic criteria is basically a list of symptoms that an individual needs to meet a minimum number in order for them to be diagnosed with a particular mental disorder. So I'm going to show you guys an example of this. So this is a diagnostic criteria of alcohol use disorder. I took it out of the chapter substance related and addictive disorders. So as you can see, it's listed there 11 symptoms. So I'll just go through the first 3 and then you guys can read the rest. So the first one is alcohol is often taken in large amounts or even over a long period of time than intended. There is also persistent desire or unsuccessful efforts to cut down or control alcohol use. The third symptom is that there is a great deal of time that is spent in activities necessary to obtain alcohol, use alcohol, or recover from its effects. Now, if you look at the bottom, in order for a person to be diagnosed with an alcohol use disorder, they need to at least meet 2 symptoms. And these symptoms need to have occurred for at least a year. What is also in the DSM is a section called specifiers, where you specify the severity of that particular mental disorders. Not all mental disorders have this, but some do. So for example, with alcohol use disorder, if the person meets around 2 or 3 of the symptoms that are listed there, then they qualify for a mild alcohol use disorder. If they meet around 4 to 5, then it's considered as moderate. And then if they meet from 6 upwards, 6 or more, then it's severe. So I hope that clears up. So this is basically a layout of how the diagnostic criteria is presented in the DSM. Okay. And then I would also like to touch on another concept that I think it's important, particularly because these days it presents a lot. What's concerning is that we see it a lot in the rehab with your teenagers. And in some instances, I'm sure you guys know of people, especially in your communities, who are considered crazy, to use colloquial terms. So we thought it would be important to include this section in our presentation. Specifically, if you remember, Dr. Markham kept on mentioning, when he was talking about schizophrenia, kept on mentioning what's referred to as psychosis. We are going to talk in detail about psychosis, exactly what it is. So I'm going to start by just briefly defining it, and then we'll discuss some of its symptoms. Okay, so briefly, just generally, psychosis is characterized by any loss of touch with reality. This includes when a person's perceptions and thoughts are disrupted, resulting in them not being able to function normally. What's interesting, and I'll explain this in more detail in the next slide. What's interesting is that the symptoms often begin between your late teens, so around 18 years to 21 years old to your mid-20s. But here's where the surprising thing is. On average, people are mostly diagnosed during their mid-30s. And I'll explain why in the next slide. So it's also important to understand that psychosis by itself can also be diagnosed. So it's in the DSM. It can be diagnosed as its own mental disorder. Specifically, it's called brief psychotic disorder, and it has its own diagnostic criteria. What's also interesting about psychosis is that it also features in other primary psychiatric or mental disorders. So, for example, bipolar can have psychotic features. Another one is schizophrenia that Dr. Markham just mentioned. What's less commonly known is that also major depressive disorder, known colloquially as depression, can also have psychotic features. So, just to go over that again, psychosis can be a diagnosis on its own. It's called brief psychotic disorder. But at the same time, it can also feature in other mental disorders. Now, the causes of psychosis I just mentioned 3, although there's multiple. There's also genetic factors in some instances, but here I mentioned 3. So the first one is environmental. As I mentioned in the beginning of this section, we are starting to find that the rehab, especially with young people who use cannabis, they present with cannabis-induced psychosis. So substances or other environmental factors might trigger a psychotic episode. And we'll just discuss this in more detail later on when I touch on the common mental disorders that feature with substance use disorders. And then, as I mentioned also, psychosis can also be triggered by another primary psychiatric condition. For example, I mentioned bipolar, I mentioned major depressive disorder, Dr. Markham also mentioned schizophrenia. And what is also surprising, what most people don't know, psychosis can also be triggered by medical conditions. Some of the most common is HIV and AIDS can trigger psychosis. Alzheimer's can also trigger psychosis. Parkinson's and your STDs such as syphilis can also trigger psychosis. Now, that's the general definition of psychosis. I'm going to get more into the actual symptoms of how it presents. Now, how psychosis presents, a way of understanding it and the way that I'd like to present it to you guys is in 2 phases. The first phase is called the prodromal period. The prodromal period is those early symptoms that most people do not recognize. Now, these symptoms can last anywhere from a couple of weeks to several years before the main acute symptoms start coming up. So I'll give an example. I had a client once at one of the tertiary hospitals who, when she was around 19 years old, presented with prodromal symptoms. Mainly, she started withdrawing from her family. There was also a decline in self-care, so she wouldn't bath as much. And also, her academic performance dropped. All of a sudden, she was performing well at school and her academic performance just dropped. Now, her mother just thought that, for example, her withdrawing from the family is just normal teenage behavior. She just wants her own space. Her decline in self-care, her mother just thought that maybe she was a bit lazy to bath or to take care of herself. And her sudden drop in academic performance was also attributed to her being lazy. Only to find out, you can imagine, almost a decade later, when she was around 29, she was then diagnosed with psychosis, because then the second phase started coming in, or the more acute stage. So just to go through the prodromal period, as I mentioned, it's those early signs that might go on for a couple of weeks to several years. With my client, with the example that I gave, they went on for around 9 years rather, before she got diagnosed. So these include, like I mentioned, withdrawing from your family, decline in self-care such as not showering as often, trouble concentrating or thinking clearly, disruption in your sleep, decrease or intense emotions, and a sudden drop in academic or job performance. Most people do not recognize these symptoms when they happen, or most people just blame the individual who's presenting in this way. Now, the phase where it is more visible or people actually start to notice the symptom is the acute phase. Now, the acute phase follows the prodromal period. These are the more visible symptoms. I divided them just to make sense of these symptoms into 2 types. Your positive symptoms. Your positive symptoms include delusions and hallucinations. I'll get more into details about that. And they also have disorganized symptoms. So these, when the acute phase starts and these 2 symptoms pop up, this is where most people are diagnosed. But it's not caught on earlier during the prodromal period. So just to start with the positive symptoms, as I mentioned, these are the most noticeable. And these are the hallmark symptoms of psychosis. So delusions, right, are any fixed idea or persistent belief that persists despite contradictory evidence. So I'll give an example. The most common is 3 of them: persecutory delusions, where someone believes that something or someone is after them. Just to give an example of this, I had a patient at one of the tertiary hospitals who believed that the government was out to kill them. And no matter if you presented evidence that the government wasn't after him, he just held on to this delusion. And another common delusion is grandiose delusion. Grandiose delusion is when someone believes that they have special talent or special power, or they're special in some way from other people. Just to give another example, at one of the tertiary hospitals, I had a patient who believed that he was a millionaire. He was an 18-year-old who presented with cannabis-induced psychosis. He believed that he was a millionaire and a forex trader. Now, there is a possibility that he was actually telling the truth. So what we did is we actually investigated this further. We sat with the parents, actually investigated whether he had some money. Come to find out, he was actually a forex trader, but he had lost money. But he was completely convinced that he was a millionaire. The last one I'd just like to touch on is referential delusions. This happens when any environmental cue the person believes that is directed at them. Just to give an example, a person with referential diagnosis, for example, will be in a room. And let's say two people are just having their own conversation. They will be convinced and will believe that those two people are talking about them. Even if those two people actually come up to the person and tell them, no, we're not actually talking about you. Remember, with delusions, it's fixed and it persists, even if you try to challenge that thought. So that's one of the positive symptoms. The other one that is also noticeable in the acute stage is hallucinations. So hallucinations basically are any perceptions or senses experienced without any external stimuli. The most common type, I'll give all 5 because mostly they come through 5 of our senses, but the most common ones are auditory hallucinations, where someone hears something that's not actually there. Remember, there's no external stimuli. So they, and mostly, especially with auditory hallucinations, they manifest as voices. It could be familiar voices, so the person could recognize the voice. For example, if it's someone that passed on. So in some instances, they could actually recognize the voice, and in some instances, it's unfamiliar, so they don't actually recognize the voice. And the content of what the voice is telling them, in all instances, it's negative. It either tells them to harm other people, to harm themselves. So the content of whatever the voice is telling them, in most or all instances, is always negative. And what's also common is visual hallucinations. Again, this is seeing things that aren't there. We see it a lot presenting, especially with people who use crystal meth, for example. They report that when they get into a psychotic state, they'll start seeing things that aren't actually there. And again, similar to auditory hallucinations, it's mostly negative content. So they'll see something that's scary instead of seeing things that are pleasant. Now, these are the 2 most common, but you do find in the other senses that we have within our bodies, we have other types of hallucinations. So you have what's called gustatory hallucinations. This happens when a person tastes something that's not actually there. So for example, a person could have not have anything in their mouth, but have this bitter taste, right? In some instances, they might actually be chewing something, but instead of feeling the taste of whatever they're chewing, they taste something completely different. And in most instances, similar to auditory and visual hallucinations, it's also unpleasant taste. It's not pleasant. And we sometimes also have olfactory hallucinations. This is where you smell something that's unpleasant, but it's not actually there. And then you also have tactile hallucinations, where you feel sensations in the skin. Remember, there's no external stimuli, so that there's actually nothing that's touching your skin. But because you're in this psychotic state, you actually feel as if something is touching you. We also see this a lot in people who use crystal meth. I'm not sure if some of you guys heard of what's called meth mites. Meth mites are, you find when a person uses crystal meth, they feel as if there's literally bugs that are crawling under their skin, and they try and scratch them out. In some instances, they even injure themselves. So that's an example of tactile hallucinations. So delusions and hallucinations, in most instances, these are the symptoms that are picked up by people Like I said, it's unfortunate that people actually don't notice someone slipping into a psychotic state during the prodromal period, because those symptoms are a bit more subtler and we could sort of blame the person for them. For example, if a person is not showering and not taking care of themselves, you wouldn't think they may be slipping into a psychotic state. So in most instances where people start being diagnosed and actually taken to hospital is during phase 2, the acute phase. And in most instances, they'll either present with delusions or hallucinations. Again, the less known symptoms, it's what's called the disorganized symptoms. These are strange behaviors that affect a person's speech or their motor movement. Here I've noted two. So it's either disorganized speech. The disorganized speech is actually underlined by disorganized thinking. And how you see this is that, one, you'll see the person, you'll ask the person one question, especially during your clinical interview. You'll ask them one question, a simple question, for example, how was your day? They'll go on and on for hours and hours talking about different topics and not stopping. This is called loose association. Now, disorganized speech can also present as tangentiality. This is, you'll ask them a direct question. For example, how was your day? They'll either answer the question vaguely or they'll answer in a completely unrelated way. So that's how you can sort of note whether they have disorganized thinking through their speech and the way that they answer your question, which is why the clinical interview is very important. Secondly, in disorganized symptoms, we also have what's called abnormal motor behavior. This causes problems, particularly if someone is trying to engage in goal-directed behavior, and this might impede their daily functioning. We have two types of abnormal motor behaviors. We have what's called catatonic behavior, which is a marked decrease in reaction. I'm sure you guys, especially with people who present with schizophrenia, if you've witnessed people in an acute state of schizophrenia, you find that they can stay in one position for prolonged period. It's almost as if they are frozen. That's called catatonic behavior. And in some instances, you also have excessive motor activity, which is called catatonic excitement. Catatonic excitement, you mostly note it if you ask the person to sit down. It's very difficult to see it if the person, for example, is moving. But if you ask them to sit down, you will see that they really cannot sit still. They'll start twitching, they'll start moving around. That's called catatonic excitement. Just to go through that again, guys. So the main symptoms of psychosis can be divided into two phases. The prodromal period is where the symptoms in most instances are not recognized, right? These can last from anywhere from a few weeks to several years. Some of the signs include withdrawal from your friends and family, a decline in your self-care, trouble concentrating or thinking clearly, a disruption in your sleep pattern, decrease or intense emotions, and a sudden drop in academic or job performance. So in most instances, these symptoms are not noticed by family members or the individual who's suffering. And then, in most cases, psychosis is caught during the acute state. In the acute state, two of the symptoms that are noticed first is either delusions. I've defined them, and as you can see the definition on your screens, or hallucination. These are the symptoms where if they occur, the person normally gets diagnosed. And those are also accompanied with the less noticeable disorganized symptoms, which I noted as disorganized speech and abnormal motor behavior. It's also important, guys, to note that a person in a psychotic episode is not aware of what they're doing or what is happening. This is very important because you find that after a person has gone through psychiatric medication and they actually come out of the psychotic episode, when you actually tell them about some of the things that they were doing, they don't believe you. Because in that psychotic state, they were not aware. Which is why it is very important when you do find a person in a psychotic state to not try, especially for example with delusions, to not try and actually convince them otherwise. Rather get them psychiatric assistance. And then once some sense of reality has returned, then you can start having some interventions. Okay. These terms I've already defined in the beginning, guys, so I'll just move on to the next slide. So in my next section, I am going to discuss mental disorders that are associated with substance abuse. I would like to discuss this relationship between mental disorders and substance abuse or substance use disorders. I guess the general question that most people ask is that, do substances cause mental illnesses or mental disorders? Or is it the mental disorders that cause substance abuse? Now, it's very difficult to give a straight answer. So establishing causality is extremely difficult. I'm just going to mention 3 reasons that it's difficult. The first reason is that any behavioral or emotional problem might not be severe enough to warrant a diagnosis, but the person might use substances to deal with whatever underlying symptom is there. Let me try and explain that. So let's say a person presents with one symptom of major depressive disorder, but they don't present with enough symptoms to actually meet a diagnosis of MDD. Let's say they only feel sad, for example. That sad feeling might be so uncomfortable for them that they will use substances, right, to try and alleviate that feeling. And then when they come into rehab, we won't diagnose them with MDD because they don't meet the full criteria, but they have one symptom of it, right? So they'll present to us as only having substance use disorder, but they do have an underlying psychiatric symptom, if we had to put it that way, which is why it's very difficult to establish whether the substance caused the symptom or because they're suffering from the symptom, they are using the substance. And also, another difficult thing is that when you're doing history taking and people are trying to recollect past events, sometimes it's difficult for them to establish whether it was the mental disorder that came first or did they start using first. And in order to establish causality, you would need to know which came first. But unfortunately, especially with people who've used for years and years, it's very difficult for them, even if they have a dual diagnosis. So let's say, for example, someone comes into rehab and they have been diagnosed with bipolar years back, right? If you ask the person, so which came first? Were you diagnosed with bipolar first or did you start using substances? If that person has been using substances for years and they've had this diagnosis for years, it's very difficult for them to actually recall which came first, which is why causality is difficult to establish. Another reason is that certain risk factors may contribute to the way certain substances affect individuals' mental health, right? So I'll give an example. If we had to say, as I mentioned earlier, that cannabis causes psychosis, the next question would be, then how come everyone that smokes cannabis doesn't have psychosis? Right? So there are other intermediate factors that contribute to a person developing that psychosis. It is not just the symptom. That is why it's very difficult to establish causality. However, I went through some literature and I also drew from my own experience. There are 3 common main pathways that contribute to the development of comorbidity between substance use disorders and mental disorders. Firstly, there is common risk factors that contribute to a substance use disorder and a mental disorder developing. A very prominent risk factor is trauma, right? So I'll give an example with that. So let's say a child is exposed to physical abuse from a young age, right? From this physical abuse, they then maybe develop a mental disorder such as major depressive disorder or persistent depressive disorder, right? Now, because they're going home every day into that aggressive or hostile environment, they might also start using substances in order to deal with the home environment. So there you see trauma being a common risk factor for both the mental disorder, which would be the MDD, and also the substance use that they're trying to deal with the situation at home, right? And secondly, the relationship between substance use disorders and mental disorders or mental illnesses is also bilateral or reciprocal, meaning that substance use disorders can cause mental disorders, and also mental disorders can also cause substance use disorders. And I'll explain this in more detail in the next slide. So just to discuss some of the common mental disorders that present, especially in the rehab context. So we're going to start with, again guys, this is not the exact diagnostic criteria of these individual mental disorders. I just summarized them. Yes. So I'm going to start with major depressive disorder, or MDD. This generally consists of symptoms such as sadness, irritability, a feeling of emptiness, decreased interest in activities, significant weight loss or weight gain. Now, you can imagine how difficult it is to live with this type of feelings. What happens is that even if a person is prescribed antidepressants, as Dr. Markham mentioned, they do have those unpleasant side effects. In some cases, a person might gain weight and they might not actually like the side effects. What some people do is they start self-medicating by using substances to try and improve or alleviate those feelings of MDD. So that's how there's an underlying major depressive disorder, which is a mental disorder, and then in order to alleviate those feelings, they then pick up another disorder, which might be substance use disorder. So for example, just to give an example, a person who's going through feelings of emptiness and sadness might take alcohol just to improve their mood. And they might take alcohol for a prolonged period until they actually develop an addiction or a substance dependence. So there you have an underlying mental disorder that eventually caused a substance use disorder. Conversely, as I explained the other way around, it might also be that substances or substance abuse can cause depression or major depressive disorder. We particularly see this during withdrawal. I'm sure for the guys who have had a night where they've drank a lot, the next morning or the next day, they might experience what we call babalas. One of the symptoms of babalas, you might feel depressed. So there you have the substance that actually causes a depressive symptom. As I mentioned in the relationship between mental disorders and substances, it can go both ways. So as I've outlined with MDD, MDD can cause a person to use substances to alleviate those unpleasant feelings. But at the same time, substances can also induce MDD. Similarly, with bipolar disorder, again guys, I'm just generally outlining the symptoms. I'm not going to go through each and every criteria in the DSM. So with bipolar, you have two symptoms. You have mania. Mania is where the person feels increased energy and they feel as if they can take over the world, but then they have episodes of major depressive symptoms, which includes feelings of sadness, feelings of emptiness, and hopelessness. Now you can imagine how unpleasant it is to experience these emotions and how unstable you might feel as an individual. Some people, in order to deal with these emotions, they might start using to alleviate these negative emotions. So there you have it, where there's an underlying mental disorder that then causes the person to start using substances. And then during the process of using the substance, they might develop an addiction or a dependence on the substance. Again, it is important to note, as Dr. Markham mentioned, and as I mentioned with MDD, some people do not like taking psychiatric medication, even for bipolar. So they prefer self-medicating by taking substances just to alleviate their mood. Similarly, also, as I explained in the beginning, the relationship is bilateral. So substances can cause some mental disorders, and mental disorders can result in substance abuse. It's the same with bipolar. There is an actual diagnosis in the DSM of substance-induced bipolar disorder. So where a person has taken substances and then they start experiencing these mood swings, where they experience mania, where they have this increased energy, they feel like they can take over the world, and then they have this major depressive episode. So substances can also cause bipolar disorder. Some other common mental disorders that we come across: anxiety disorders. So I just outlined, this is a whole chapter in the DSM. This includes such disorders as phobia, social anxiety disorder, generalized anxiety disorder, panic disorders. The one thing or the one feature of anxiety is fear, particularly fear of the future. Now you can imagine being constantly in fear of the future, how uncomfortable that is. Now again, in order to escape those feelings, some people might start using substances. In the process of using substances, they might then develop a substance use disorder, or they might become dependent on whatever substance they're using. And also, similarly, psychoactive substances might also cause anxiety. There is a diagnosis for substance-induced anxiety disorder. And then Dr. Markham also mentioned that personality disorders are very prevalent, especially in our context in the rehab. So here I mentioned two, which come up with a comorbid substance use disorder. The first one, borderline personality disorder. So generally, this is just a pattern of instability. In your personal relationships, the person doesn't have a stable self-image of themselves, and their emotions are also unstable, and they're very impulsive. Now, you can imagine this personality makeup. So what accounts for the substance use disorder is mainly two things. The unstable emotions that the person experiences is uncomfortable. In some instances, they might use substances in order to deal with these emotions. It's also important to note that people with borderline personality disorder are also impulsive. So they just act before actually thinking, which makes them more predisposed to actually using substances. Just two more to go, guys. And then the fifth one, we also especially see it with people who service in the police, is PTSD. So the full name of it is post-traumatic stress disorder. This is any exposure to an actual or threatened death, serious injury, or sexual violence. Either the person directly experiences it or sees someone else experiencing it. This might cause symptoms such as flashbacks. The person might avoid the context or the environment where this thing happened. They might also be anxious, hypervigilant, and they might also have sleep disturbances. Now, you can imagine some of the symptoms that I've noted, how uncomfortable these are. A person might use substances in order to deal with these symptoms, instead of, for example, seeking therapy. Also, what's important or very interesting to note is that can you imagine someone who actually abuses substances? In most instances, the places where they hang out is dangerous places. So they are more prone to be exposed to trauma and to later on develop PTSD. So there you see the bilateral relationship between substance use disorder and PTSD. Lastly, Dr. Markham mentioned psychopath. In the DSM-5, it's mentioned as antisocial personality disorder. And basically, this is just a person presenting with this disorder has a total disregard of other people's rights. They also engage in criminal behavior, they're impulsive, and they have an inability to learn from previous mistakes. Particularly with this last symptom, this is the reason that you find people with antisocial personality disorders, they keep going back to prison over and over. It's this inability to learn from their previous mistakes. Again, you can imagine, if you remember in my definition of substance dependence, or some of the symptoms of substance dependence, we mentioned substance seeking behavior. Substance seeking behavior includes some of those symptoms of antisocial personality disorder. For example, a person might steal from their family. A person might break the law. That are symptoms that are part of antisocial personality disorder. And also, just generally, people with antisocial personality disorders are attracted to that type of life of using drugs and going out every night, because they just have this inclination to just act impulsively. And yeah, those are the common mental disorders that we come across in the rehab.